Welcome, viewers. A scientific seminar on cardiovascular diseases was held on 3rd September in Community-based Medical College Hospital, Gallery number 1. Department of Cardiology presented in this seminar. Director of the hospital, Community-based Medical College Hospital, Professor M. Karim Khan presided over the seminar. Principal Professor Dr. Mahfuzur Rahman Khan Chaudhary was chief guest of this seminar. Please watch the recorded part of the video.
This is Dr. Tofayel Ahmed. Before I get started, I would like to thanks and gratitude to our principal and our director sir for give us the opportunity to arrange this type of scientific session. Also, I would like to thank our three panel of experts, my senior and junior colleagues, and my beloved student for active participation. Now, I would like to talk about the new enemy in cardiovascular disease, that is left ventricular failure with preserved ejection fraction. Heart failure with preserved ejection fraction, that is HFpEF. I will show you the following headlines: introduction, etiology, pathology of the HFpEF, clinical presentation, diagnostic testing, therapy, and the take-home message. Let's get started. HFpEF, heart failure with preserved ejection fraction, is the preferred term over diastolic heart failure. Diastolic heart failure may be defined as sign or symptom of congestive heart failure, normal or mildly abnormal left ventricular function, evidence of diastolic dysfunction. Heart failure with preserved ejection fraction, HFpEF, which currently represent approximately 50% of the heart failure, is common and associated with high morbidity and mortality. Patients with HFpEF are predominantly elderly, more likely to be female than male, and have the high prevalence of comorbidities such as hypertension, coronary artery disease, diabetes mellitus, anemia, COPD, atrial fibrillation. The prevalence of HFpEF relative to the heart failure, reduced ejection fraction, increase at the rate of 1% per year. HFpEF is on the track to become the most common type of heart failure in the near future. It is also known that rate of hospitalization in HFpEF is equal to the HFrEF. What causes it? The most common causes of diastolic heart failure is the natural effect of aging of the heart. As your heart ages, your heart muscle tends to stiffen, which can prevent your heart filling. But there are many health problems that can impair your ventricle to ability to relax. Causes of the diastolic heart failure: coronary artery disease. Coronary artery disease impairment weaken the heart muscle, and that's why relaxation abnormality and feeling defect. High blood pressure. High blood pressure causes the hypertrophy of the muscle, that also relaxation abnormality. Aortic stenosis, which also causes the hypertrophy of the muscle, that relaxation abnormality. Hypertrophic cardiomyopathy also has the relaxation abnormality, that is diastolic heart failure. Pericardial disease. Pericardial fluid or thickening of the pericardium, also relaxation abnormality, that causes the heart failure with preserved ejection fraction. Factor that exacerbated the diastolic heart failure: uncontrolled hypertension, atrial fibrillation, non-compliance, myocardial ischemia, anemia, renal insufficiency, use of NSAID, and dietary indication with over salty food. Pathophysiology, low cardiac output that result typically from the variant ventricle thick wall and small cavity. That's why cardiac output less and causes the fatigue. When the left ventricle stiff, the relax slowly, early diastolic and late diastolic pressure also elevated. While, while the high in diastolic pressure increase the pressure of left atrium and increase the pressure of pulmonary vasculature and causes the heart failure. The pathophysiological abnormality triggered also neurohormonal activation that also causes the left ventricular with reduced ejection fraction. Clinical presentation. Symptoms of the diastolic heart failure indistinguishable from the systolic heart failure. It also causes the symptom of shortness of breath, blurring of vision, fatigue, confusion, lack of exercise, palpitation, vomiting, and edema. Dyspnea is the early feature of the symptom. Sign of congestion may be absent. Overall, none of the following clinical signs can reliably distinguish from the systolic to diastolic. Diagnostic testing, ECG. A normal ECG does not exclude the diastolic heart failure. Mainly common left ventricular hypertrophy. Chest X-ray may be normal and may occur cardiomegaly. Specific laboratory testing is the B-type nitrotic test and NT-proBNP, but not exclude the diastolic heart failure. Echocardiography. Echocardiography is the best modality to assess the diastolic heart failure. Transmitral flow pattern E and air ratio less than 1 and transmitral deceleration time more than 220 and pulmonary venous flow as the difference more than 1 and flow propagation velocity m mode from b less than 45. All the picture are taken our echo machine and we have need the powerful machine that is with artificial intelligence. The TDI is more than 8 when it is need the artificial intelligence machine, and another modality is speckle tracking, which is fully artificial intelligence mediated machine, and a four chamber view is taken, then machine automatically give us the systolic and diastolic function. And we others examination we also do cardiac MRI and endomyocardial biopsy. Treatment. No treatment has shown to be the effective for the diastolic heart failure. How is diastolic heart failure treated? Achieve and maintain the healthy weight, eat low sodium heart failure diet, treat high blood pressure, wear CPAP machine if you have the sleep apnea, exercise for at least 30 minutes most days of the week, and smoking or using the tobacco, avoid smoking and tobacco product. Maintain symptomatic treatment with diuretics. Systolic and diastolic blood pressure should be controlled. Coronary revascularization should consider in patients with coronary artery disease. Ventricular rate should be controlled. SC inhibitor known to be reduce left ventricular hypertrophy, and digoxin has been used to reduce hospitalization. Role of potassium sparing diuretics is unclear. Nitrate and positive inotropic as it should be used with caution. New anti-diabetic drug, SGL2 inhibitor, reduce the risk of cardiovascular death and hospitalization in HFpEF. Take home message. HFpEF is responsible for about half of the heart failure. Morbidity and mortality associated is high and similar to the left ventricular dysfunction. 20 2 to 29% patients with HFpEF die within 1 year, and first hospitalized, and 60% die within 5 years. Old age, hypertension, female sex are commonly associated. Non-invasive imaging technique can be used for diagnosis. At this time, further studies are needed to determine the equal treatment strategies. ফাইনালি আমি একটা কথা বলতে চাই, যে কোনো শ্বাসকষ্টের পেশেন্ট, অ্যাজমা হোক, অ্যালার্জির কারণে হোক, সিওপিডি হোক, you must do a echocardiography. This is the guide. Thank you for patient sharing. Assalamu alaikum.